Hi, I'm Dr. Satish Nair. I'm an ENT and head and neck surgeon. I specialize in minimally invasive endoscopic and robotic surgeries of the ear as well as the head and neck pathology. There is a part of ENT and head and neck surgery which is advanced further than what the remains of the basic nose and the ear are, because most of these areas are in close proximity, or the roof, for example, the roof of the nose is the brain, the roof of the ear is the brain again. So these are the areas called skull base, the base of skull. So there are rare, but then there are lesions or tumors which do develop in these areas, and these areas being in very challenging place requires a little bit of expertise to reach them and treat them. The endoscope has revolutionized things. We can go through the nose and evaluate a lot of things that is there in the skull base and treat. So a lot of surgeries which used to be performed by an open approach earlier, with the neurosurgical approach, I would say open approach outside, do a craniotomy, and now can be approached through the nose transnasal if they're involving specific areas of the roof of the nose, or we call the anterior skull base. This is the anterior skull base. So from anterior skull base, CSF leaks to tumors to pituitary adenomas are usually nowadays treated through the nasal cavity by endoscopic skull base surgery. There are also tumors which are there in the next to the ear, the skull base in the ear. But then here the difference between the anterior lateral skull base is that these tumors are usually present. They are vascular tumors. They bleed a lot, and a lot of very, very important structures pass through it. Many of them are tumors which can be from the nerve, schwannomas, slow growing tumors. With the vascular paragangliomas or the glomus tumors, again, slow growing tumors. These are not cancer tumors, but these are very slow growing tumors. And I would say yes, one of the treatment available is observation. So patients asymptomatic, just picked up small tumor, can be kept on observation because the growth is usually less and it's not producing a symptom. Number two, smaller lesions, particular size, there's definite role for stereotactic radiosurgery. Instead of surgery, you have radiations being given which can stop the growth of the disease or arrest the growth of the disease, arrest the growth of these tumors. For example, some of the vestibular schwannomas, the acoustic neuromas they were called, and these are at the CP angle right at where the nerve to the ear comes. So they have been treated now. Most of them are treated earlier, treated by surgery with a lot of morbidity, other nerve involved. Patient has a lot of other problems. Now treated with stereotactic radiosurgery. Similarly, the glomus tumors, the glomus jugulare, as well as other schwannomas of the skull base, lateral skull base, can be well treated with stereotactic radiosurgery. Last would be, I would put as surgery. Because surgical reason, the reason I put it last is because when they're large tumors, definitely you cannot do stereotactic radiosurgery, or you can't be observing them. They're already producing pressure effects. They are already pressing onto other nerves. Nerve palsies are already there. Then you need to definitely go through surgery. So the lateral skull base surgery, where the surgical process is performed through the ear, with removing the cells from there and then removing the disease from there. Definitely technically challenging surgical patterns. So that is why the lateral skull base I would put as observation, stereotactic radiosurgery, and finally as surgery. Thank you very much.